So we don't have any conflict of interest or disclosures. So let's start off with the case. Mr. B is a 73-year-old man with a history of CVA, cervical myelopathy, admitted to neurosurgery for a C-spine laminectomy infusion. On post-op day 3, patient had a VT arrest secondary to acute hypoxia. Code blue was called, CPR and naloxone were administered, and the patient was transferred to the NICU for further management. The wife was in the room at the time and stated that she had brought in heroin for the patient to use. The patient was I actually took care of this patient in the IMC last summer. The patient told me after coming out of the ICU that he had used heroin in the hospital because his chronic and acute pain were poorly controlled. Unfortunately, since then, we have had at least 7 other cases of a similar scenario where patients have used street purchased opioids in the hospital, resulting in accidental overdose at Georgetown. So in this talk today, I hope that by addressing some of the stigma that we have as medical professionals, as well as utilizing the protocols that we have created here at Georgetown and implemented at Georgetown, we hope to reduce some of these cases in the future. Our objectives today are to review the state of the opioid epidemic in DC, analyze the successes and challenges that MedStar, to the steps that MedStar has taken to address these evolving challenges, and discuss best practices for improving our clinical practice in the treatment of people with opioid use disorder, substance use disorder, including systemic and legislative changes. Unfortunately, we are no strangers to the opioid epidemic in the United States. In the last year alone, over 100,000 overdose deaths were reported. 75 of those involved opioids. 3 in 5 patients who have died from drug overdose had an identified opportunity for linkage to care or life-saving actions. These opportunities include access to naloxone, treatment programs, prior overdoses, potential bystander present, or mental health diagnosis. As we will see, people with OUD also utilize the emergency department and hospitals more frequently than those people without OUD. This makes the emergency department and hospital ideal opportunities to initiate conversations for treatment of opioid use disorder, but we are bad at it. Only 87% of patients who have OUD, 87% don't get treatment for opioid use. And from the ED, 92% don't get medications for opioid use. Bringing it home to DC, in 2021 alone, there were 424 total overdose deaths from opioids at a rate of 67.6 deaths per 100,000. That puts us number 2 behind West Virginia. If we include all the patients who died from cocaine as well that year, that actually puts us at number 1 in the country for overdose deaths. And as you can see up here in the right-hand corner, 80% of those patients had at least one opportunity for intervention. Outside of overdose deaths, we know that opioid use disorder affects our patients in so many other different ways. It increases morbidity, mortality. We know our patients have increased rates of HIV, Hep C, have more injection drug use related infections, including cellulitis, osteomyelitis, and endocarditis. Furthermore, it also affects patients in many other social ways, increasing risks of housing and food instability, criminal justice contact. It affects their employability. It creates family and social stigma, creates physical trauma, and puts these patients in risk environments. In healthcare, we see it very frequently, and we know that it increases overall healthcare costs and increases workload. For patients with OUD, it increases patient readmission for the same condition, increases the number of ED visits after the initial hospital stay, usually 4 to 5 ED visits per year after a hospital stay, after discharge from a hospital stay. And it also increases length of stay for the same condition. This is due to inherent mistrust of the medical team due to a history of stigma. It causes delays in access to healthcare, decreases compliance, and decreases the quality of care. patients are sicker when they present to the hospital. There's increased rates of patient-directed discharges in this population. 30% was an average, but I saw up to 50% discharges related to opioid use disorder. And of course, that leads to increased readmissions. It increases the rate of treatment failure, and we already talked about length of stay, and also increases the risk of death. So going back to our patient case, this patient, as we were planning for discharge, the patient just had major surgery for cervical myelopathy. He was recommended for subacute rehab, but because of his substance use in the hospital, as we see all too often, there was no rehab facility in the area who would accept him. As a result, the patient was discharged home, wheelchair bound, and with a Foley catheter and for acute urinary retention that the patient didn't have prior to this hospitalization. The patient subsequently had 2 additional admissions for recurrent urinary tract infections over the last 8 months that I could see as of yesterday in the MedStar system. So could these admissions been potentially preventable? So the idea that hospitals are a high-risk environment for RUD came about. Rhodes and McNeil describe social structural forces that negative biases in the provision of healthcare and leave patients vulnerable to undertreatment and harm once they're admitted to the hospital. Patients with OUD tend to be given dosages of pain medications that don't account for the heightened tolerance that they might have as a result of their OUD. Patients also face stigma from medical staff and negative bias against them if their opioid use history is known. It makes them reticent to admit to their opioid use history, leading us to undertreat them and therefore, and also the way we use language like drug seeking perpetuates everyday violence against patients who experience OUD. As a hospitalist, I think, and those of us practicing inpatient medicine, we see a lot of nausea, vomiting, intractable pain, irritability. They're all non-specific symptoms, but without a heightened sensitivity to look for these symptoms in the context of opioid withdrawal, they may be ignored and undertreated. This leads to increased patient-directed discharges and also self-administered opioids while in the hospital. This makes their lives worse and our lives harder. So MOUD, or medication for opioid use disorder, comes by many names. Another, we might have seen medication for based treatment or medication assisted therapy treatment. They're all different acronyms, but all mean the same thing. And they all refer to the buprenorphine, methadone, or naltrexone that we can use. And we've seen that these reduce morbidity, mortality, and reduce healthcare costs. In the hospital, one study showed that just continuing patients' methadone in the hospital can reduce patient-directed discharges by 50%. But medications are not the magic bullet as much as we as internists like to refer to them as such. We need the support of peers. So I'm going to pass the mic over to Thaddeus to introduce himself and introduce the role of peers.
Okay, so I'm Thaddeus, a peer recovery co-chair and the Overdose Survivor Outreach Program coordinator or coach. SBIRT, as you might have seen in the documentation section, stands for Screening, Brief Intervention, and Referral to Treatment. What we do is provide a very quick assessment based on our patient interaction of if this person is appropriate for various levels of treatment, substance abuse disorder treatment, or medication assisted treatment like Suboxone. Our philosophy is that the people with a history of lived experience with substance abuse and skills in motivational intervening who help people with substance use disorders develop the motivation and recovery capital necessary to initiate or maintain recovery. So kind of briefly, we use our lived experience as a person in recovery to create a quick rapport with the patient, to establish that we're not a doctor or a nurse, but we are a professional in healthcare, that if they want it based on the answers to their own questions of their life circumstances, the help is there. I have a privileged position in this hospital to be able to speak from my own experience. I'll share a little bit of that with you right now. I'm a walking, talking statistic of the opioid epidemic. I'm a recovered IV heroin user. I use AA. It helps me greatly. And I try and get with my patients and share some of my relevant experience to motivate them, and if the willingness is there, create a plan moving forward to get them into recovery themselves. Quite briefly, I was, at 15 years old, I was skating as a kid in 1996 before cell phones. Broke my arm. My bone was popping out of my arm. Went to the emergency room at Arlington Hospital, and I spent 5 or 6 hours until my folks got there and they could administer me pain medication. It was a really traumatic piece for me, but all of my other childhood wasn't traumatic. It was, I never wanted for anything. When the morphine came through, there was a moment for me of everything made sense in the world. And slowly but surely, as kind of the dominoes fell in my life, I started to seek that sensation more, and then always, and to the point where, as we all know, if you read the Washington Post or anything like that, the opioid epidemic took root. Opiates became more available, and it turned, my life kind of turned from why can't I feel this way all the time to I have to feel this way all the time, leading to a lot of very bad things. But I use that experience today in the hospital with people to say, look, I understand what it's like. I've overdosed, I've had seizures, I've gone through withdrawal. I know what you're feeling right now. I understand that shame and embarrassment of being able to speak freely and openly with professionals who have their life together. So oftentimes that does establish a very quick rapport, and we're able to then say, okay, well, where do you want to go with this? It usually is a 15 to 20 minute interaction. And if they get admitted to the hospital, it's, follow up as well as many times as they can stomach, while creating a recovery support plan. That's a brief, that's good. Yeah.
Thaddeus always undersells how much his role is, but we'll come back to brag about him too.
Well, first I'm going to brag about how great peers are. There are people like us to have Thaddeus in our system. There's been a lot of studies that have shown that peers work, and it is very cost effective. So there was a Hopkins study that was done at our 4 Baltimore hospitals, specifically, that was just published last year, 2 years ago. 2020, that looked at pre and post peer introduction into their program, their hospitals in Baltimore, and it showed that it cost the hospital over $1 million per year just by having this program in place and taking care of opioid patients with opioid use disorder in the hospital. What did I say? Cost. Oh, sorry. So clinically, it reduces, peers reduce ED utilization. It also reduces patient-directed discharges and readmission rates. And it also connects patients to outpatient care. Peers also help in creating unquantifiable interpersonal advantages. And some of those include they're effective in improving relationships with treatment providers. I don't know how many times I've walked into a patient's room and talked to them about their opioid use disorder. They've said, Daddy's already talked to me. He said I should talk to you about it. And I think that really strengthens the provider relationship. So again, really great having Thaddeus around. It increases treatment retention, increases access to social supports, increases greater housing stability, decreases criminal justice involvement. All of these things we know for our patients will improve their health outcomes, which is the most important piece. So at Georgetown, our response to the opioid epidemic over the last several years have been tremendous, actually. So it has been a massive collaborative effort with grant funding from DCHA that began a few years ago, sometime during the pandemic. It involved nursing, physicians in both emergency medicine, hospital medicine, and psychiatry. It also involved IT, peer recovery coaches, and pharmacy. It began with a ED initiation protocol for buprenorphine, and then it expanded to the inpatient side last year. The protocol was developed by Dr. Amar Shahi, who is a toxicologist and addiction specialist over at Washington Hospital Center. And Laura and I have helped to provide education to our hospitalist group, the internal medicine residency programs, the psychiatry programs, and I know Laura has done a lot of education with the emergency medicine residents to utilize the protocol. It involves universal screening for substance use. The unique part of this is that hospitalists and ED physicians can initiate buprenorphine without inpatient, in-hospital addiction medicine support. So it really allows everybody including surgeons, to also initiate buprenorphine using this protocol. And it also integrated peer recovery coaches to facilitate therapeutic relationships, increase patient engagement, and connect them to treatment. Just as a quick overview of the workflow, hopefully you guys have seen this before. Every single patient in the hospital is now screened for drug use and alcohol use. Any positive screen is referred to the PRC, and the PRC provides brief intervention and assesses interest in buprenorphine initiation. We utilize the protocol and the order set to initiate COW scoring and initiate induction and maintenance therapy with buprenorphine. And ultimately, the peers will help set up the discharge planning. Our goal eventually is to have take-home naloxone as well on all the floors. The nurses are all trained to screen all patients. It began in the ED, as I mentioned, last year as a pilot program on West 4, 5, and 5 West. We had screening starting last April, and it rolled out to the entire hospital except for the OB and the pediatric departments in October last year, which was very exciting. You can see these notes for the residents who are admitting or providers, just to see what history, what contact they've had with SBIRT under nursing documentation. And we're working with IT right now to create a filter so that all SBIRT notes from the nursing and from the peers across the MedStar system can be seen under a single filter, so that you have an idea of where these patients have come from and how many contacts they've had with the system. A drawback could be that patients will withhold information. Last week, Thaddeus and I had a patient where I admitted a patient who had a positive fentanyl tox screen and had history of utilizing Suboxone in the past, but was no longer utilizing Suboxone. And I saw Thaddeus in the emergency department and said, "Hey, are you seeing so-and-so?" And he said, "No, they didn't pop up on my screen." So apparently, I guess the patient had withheld information in the emergency department when the nurse had conducted the screen. So I think there is also some patient fatigue with having this. So I think that just goes to show how important it is that we as providers also play an important role in this as well in identifying patients who have OUD. So here's a copy, a screenshot of the order set. Has anybody used this order set? Yay, awesome. I want to bring it to your attention. It's the new order set. Apparently there's several others and we're working to try to remove the other ones. But the most important thing is everything here is preset. It should be very easy to use. The cows are all pre-checked, and don't uncheck them. Those are all for the nurses to be able to order the correct cows scoring pre-timed at the right times. And the only things that are not checked are the adjunctive medications. So the ondansetron, the clonidine, the ibuprofen, as well as the loperamide. And that's so that providers can decide on their own if patients have low blood pressure, if kidney injury, not to use those medications and maybe seek out other adjunctive medications. Here's how the CAL scoring look from the nursing standpoint. They will check through and look at pulse rate, sweating, restlessness, pupil size, all the things that we think of with opioid use withdrawal. Once this CAL score is greater than 10, a patient is eligible to use 4 milligrams of buprenorphine. And then the nursing will administer CALs hourly and administer by increasing doses of 4 to a maximum of 12 milligrams until withdrawal symptoms have resolved. It's really important to make sure the patient is withdrawing before starting buprenorphine because we don't want to cause a precipitated withdrawal, which we'll go into more detail later with pharmacy. Just a reminder of the exclusion criteria for our particular protocol: severe decompensated liver disease, pregnancy with impending delivery, acute psychosis or severe medical illness, or requiring acute or chronic pain agonists with full agonists. So these are in our protocol, but we'll go through a little bit more later about how our protocol is a great starting place, but it is not the end all be all. So I think that opens up more room for discussion. And as I said before, medications are not our only treatment, so I want to turn the mic back to Thaddeus.
I just want to, Thaddeus is going to undersell himself, so I want to really highlight the fact that this is sort of the review we have of what peers do, and Thaddeus cannot nearly tell us enough about what his value and role in actually doing these screenings are. So whatever he says, magnify it by 10. He says so much more than we're describing.
Thank you. I appreciate it. So our basic workflow in Espert is all the patients are screened, 18 and up. Everybody gets screened. We get flagged. Our priority area is obviously the ED because it's a quick turnaround, but anybody inpatient now, as they mentioned, we rolled it out to all inpatient levels. So with the Espert filter that I have, I can quickly see a snapshot if they've been to other MedStar hospitals in the area, how many times they've been charted, how many times they've been to treatment, all relevant information, if they've ever been on buprenorphine before. Our brief intervention is generally a 10 to 30-minute conversation. I generally go in and I explain I'm not a doctor or a nurse. I talk about some of my lived experience with them if they're willing to go through that, but it really is a give and take. If you went in there with a clipboard and a bunch of set questions, it's not going to go well. Whatever they're willing to give you in that brief intervention, you take it and you run with it. Generally, we go through a bunch of demographic information, their housing information, the substances they've used, their frequency of use. We talk about withdrawal frequently. Based on their answers to their questions, the referral to treatment part is very, very simple. Obviously, some people that we see here are appropriate for an outpatient referral, but a lot of the more severe drug and alcohol use that we see, an inpatient referral is the simple answer. Again, treatment is not the be all end all of this. There are various other ways, AA, NA, Alcoholics Anonymous and Narcotics Anonymous, along with medication-based treatment can be effective for working people, people with families that can't step away, or people with, jobs and stuff that can't take the time to do inpatient treatment.
One thing I want to add, just as like a polling the room real fast, if your patient came in and told you they're using 3 blues a day, who can tell me what that means? How much, what kind of drug is that? Anybody? If they're using boot, what are they using? Ice? I feel like we should know ice.
Ice is meth.
We watch TV, guys. So I think what that is maybe not selling himself enough on of just sort of this this power dynamic between patients and providers, particularly people who are using street drugs and have a history of being stigmatized for the medical audience. Even if they're willing to open up to us, a lot of the time we don't know what they're talking about. And I think that is his role in both narrowing that power dynamic and being a safe person for patients to talk to, and then just translating of like, you're using 3 blues, what kind of withdrawal is that patient going to go through? I could make a guess, but like Thaddeus can tell us that is a severe disorder versus that's mild, and sort of help guide how are we going to shape our clinical treatment based on what does this mean? Because I don't know, I don't have time to learn every lingo for every street drug. So I think
Well, that's a great point too, because blues used to be Roxy 30s, right? Like they used to be Percocet, but blues now it's all fentanyl, it's all pressed fentanyl, all throughout the DC area. All of what we see is fentanyl, and in the heroin, it's 98% of the syringes we test from the needle exchange have fentanyl in them now. Whether or not how much is another part of it. Another aspect of what we do is harm reduction here. So I pass out fentanyl test strips with instructions how to use them, my contact information, because a lot of people may not be done using, but if they keep your card and they can use these things that might keep them alive long enough to say, what, I do want to do something different. And we might get a call 3 months down the line. So I don't give out these fentanyl test strips to, I do give them out to heroin addicts and opiate addicts, but granted that it's in 98% of the opiate supply in DC, I usually give them to cocaine, methamphetamine users, crack, boot. Oh yeah, Xanax is usually pressed these days and can contain a lot of fentanyl. But boot, as Dr. Haseldon mentioned, is kind of an amalgamation of MDMA and whatever else you got. As far as I know, it means it was stepped on. So there's part MDMA, maybe some bath salt in there. There's a lot of different things, but that was a new term that I learned a year ago here, and it kept on getting kicked around long enough until I was like, okay, I have to figure out what this is and why people are using it. So,
and I do want to say Thaddeus does a lot of social work, community health kind of tasks with housing and sort of determining these levels of care. But I think it's really easy for us to sort of think that Thaddeus is a social worker. Thaddeus isn't a social worker. Thaddeus has this entire field of expertise that we don't necessarily recognize always as a field of expertise. So if he comes up to you and says, hey, this is what you can expect as far as this is going to be a really bad withdrawal, maybe you're underestimating what it's going to be like, listen to him, he knows.
Appreciate it. But yeah, the game has really changed with the advent of fentanyl and the way that we treat things and the way that we dose buprenorphine and everything, because with the substance that's 50 to 100 times more powerful than the regular street dope that they used to be, we need to react. I also do outreach as another part of my job. So if patients, especially opiate using patients, are willing to meet up and have a cup of coffee, maybe they're not willing to commit to a plan day of, they can call me, we can arrange an appointment, and we can work on a plan in the community, which is another wonderful part of my job.
Me. Okay, so we've done a ton of work. Dr. Amrachai and Dr. Poon have done a ton of work to sort of build these protocols, and we've done a lot of really great starting point interventions, but all of this is sort of run by the DC Hospital Association. It's all grant funded, so all of it's metricized. We actually have the numbers of how this program been doing month by month over the past 27 months since it went live. And overall, we've made some really good progress. We're doing a great job at screening. Our goal is screening 75% of all patients that come through the hospital. Over the past, I think it's the past like 11 months, we've been close to 90%. We're doing a really good job of that. We are doing Thaddeus and Ruthie is our other peer coach, are doing a great job of doing our brief interventions for patients that are screening positive. We're pretty much right at goal for that. If you look at these numbers, one of the things that is actually making our numbers look a little bit worse is we have historically included THC as a positive screen. So our peer counselors are supposed to try to do an intervention on anyone who smokes weed, which is pretty challenging, and also not patients that are generally in need of or amenable to any sort of treatment. So one of the things we're working on now is removing that population. So it's going to make our numbers look better appropriately. So one of the things on this that looks like we're not doing a great job, which I think is a measurement error more than anything else, is it looks like our linkages to treatment are pretty challenging. This is within the context of the DC hospital system. It's just really challenging to measure this because we're sending to different networks of care that we can't get all this information for. I think our numbers are actually better as far as people were referring to treatment. It's just very hard to actually measure that. So despite the fact we've done a great job of doing this nursing education, of doing these protocol rollouts, of doing these screenings, we're still having a lot of trouble getting people actually started on buprenorphine and started on any sort of MOUD in the hospital. So the TLDR of this is a hard graph to read, I know, but the TLDR is that 17 patients in the past 27 months have been documented at being initiated on buprenorphine, which I
don't think is an accurate number for a couple of reasons. The way we're measuring this is explicitly from Thaddeus's documentation and not from our pharmacy numbers, not from our protocol utilization numbers. That said, I do think we're not using a lot of buprenorphine. Have any of you started buprenorphine on a new patient? Said 2 people have used the order set. So yeah, so most people are not starting buprenorphine. I think we have Sumeet texts me pretty much every time we start someone on buprenorphine from the ED, and I know of about 5 since I've been here for the past 2 years. So we're not doing a great job of this. I do think we're under measuring it, but we're also just not starting a lot of people on MOUD. There's a lot of reasons for that. Thaddeus is going to help us unpack some of the reasons that have to do with patient preference. We'll talk a little bit about why we're not doing a good job as physicians. So let's do that. How are we going to make this better? We have this beautiful protocol. We have a lot of resources and support for this, but we haven't actually made a lot of progress in actually starting. So we've identified this as sort of 4 major areas of challenges, and hopefully we have some solutions for you. A big one being patient preference, which Thaddeus is going to talk about, and ways that he as our peer, and then we as providers can start to unpack some of this patient preference and maybe start having a little bit more of a conversation with our patients. There's some gaps in provider knowledge, which we'll go through. There's some logistical challenges, which we've addressed a lot of and will continue to address. And if we have time, there are some systemic and political advocacy barriers, which we might skip if we run out of time. But if you want to talk about legislation and how to make legal change, find me afterwards. So we'll hand back over to Thaddeus to talk about patient side.
Okay, so the patient preference and stigma that we run into here in the hospital a lot, there's a large preference for methadone for many reasons. Methadone's been around for a lot longer of a period of time. That's a major part of why it's so prevalent here in DC. There's a lot of preconceptions that come with Suboxone in a lot of different communities in DC and just in general. It's stigmatized. A lot of people haven't had an appropriate education on what precipitated withdrawals are, and they've experienced them. They've had negative experiences, in the hospital, in real life, and they just don't want it for that reason. To get someone onto Suboxone successfully, they have to be in a long period of withdrawal, like a bare naked withdrawal, and feeling those uncomfortable things that they spent very, very long periods of time trying to avoid. So 9 or 12 hours of withdrawal to get you onto Suboxone easily. A lot of our patient population isn't necessarily willing to do that. And that makes it very difficult. And if they undersell their answers to get the Suboxone sooner, they're in precipitated withdrawal, and it's a continuing issue that we see. The inadequate dose of buprenorphine history, I mean, like I mentioned earlier, with the advent of fentanyl, the things have just really changed. And so people, are doing unfettered and unregulated amounts of fentanyl out there, and sometimes doing straight fentanyl, oftentimes. So the 4 milligrams that we used to give to the average heroin user isn't cutting it for them. It creates a very bad situation for them here in the hospital. They immediately, want to leave and use, and they're uncomfortable. And I guess that's, understandable in a way, that they want to go back to what they know will work for them, because this hasn't. The history of protracted withdrawal coming off buprenorphine, on Suboxone, I dabbled in Suboxone many times. I was on it from a provider as well. Coming off of it, is a slow taper. And once you're finally off of it, it's 3 weeks of very uncomfortable times, and it gets a little easier as you go, but it's extremely uncomfortable. I know that from firsthand experience. So a lot of people know that. They've dabbled in these things on the street, and they know that they don't want to have to go through that longer period of uncomfortability in recovery, and so they opt against it. Suboxone does have a very bad taste. I know that from firsthand experience too. It's an orange taste. It has there's just something very off-putting and medicinal about it. A lot of people don't like that. I also experience it, the feeling of it coming out of my pores several hours after, it was working, but there's a sensation, and I can't really explain it other than that of there are plenty of reasons why people say, no, I don't want that. In AA and NA, there is some stigma to MOUD users that say Suboxone is not sober. I hear it all the time. People make jokes about it in the rooms. That is not to say that it's not welcome there. I use AA myself, and anybody who's on it and willing to give recovery a shot, I'm there to help them every step of the way, including coming off it and keeping sober support around them. But in other rooms of AA and NA, it is frowned upon, as you're tethered to a substance, and it's not something that you should be doing in there. Oftentimes people say it is replacing one drug with another. My argument is it's a much less harmful drug and a much less life-destroying drug, and you can actually give it enough time to rebuild your life, if you're away from the substance. So this is where we come in as peers, and we try and say the benefit of this is give it enough time without that substance, without that hustle behind it, without the preoccupation, and you'll experience, your life improving, because you don't have these things. You don't have to chase this money all the time and chase the drug. Yeah, pretty much.
There's also a policy history behind that I would love to rant about, but we won't right now.
Okay, this is you.
I think it's just.
Yeah. The methadone preference. I'd be remiss not to say that there is a certain subset of this population that it just isn't done using and doesn't want to stop. So when we go into the room and we're like, oh, we'll get you fixed up, and some people just know that that's not them, we have to keep that in mind as well, that they might not be as forthcoming with that answer as we would like, but there is that patient subset that just doesn't want it and doesn't want to stop. Methadone. Yeah, you do it.
So this is like one of my favorite articles that I'll actually send you guys, but methadone in particular, one of the things people have a lot of preference for it if they do want to continue using, which is fine. If they want to like continue using full agonists, that's, we're not going to change their behavior by bullying them. So just give them methadone or connect them to methadone as a form of harm reduction. One of the things that Thaddeus and I have actually talked about a lot is this theory of minimally disruptive medicine, where it's really hard to use methadone on a daily basis. I don't know if most of you know, there are only 4 OTP clinics in DC. So there are only 4 places people can get methadone in DC. For a lot of states, it's like, I don't remember which state, but there's a couple, I think South Dakota doesn't have a single Medicaid funded methadone clinic in the state. So people are driving 2 or 3 hours each way a day to get their dose. So if you're having this conversation with your patient about like, hey, you want to get some of your life back, you don't want to be on withdrawal, but they have a preference for methadone, I think the conversation of how can we sort of suggest maybe buprenorphine might be a better option if they want to go back to work, if they want to go back to being a primary caregiver, is you get 2 hours of your day back by not waiting in line at these methadone clinics. You're not doing as many daily check-ins, as many drug screens. So the buprenorphine, I think if we use it in a humanistic way, it gives people a lot of opportunity to have sort of some autonomy and some independence and just some not being treated like a criminal, as I think you phrased it before, at a methadone clinic, to sort of just treat it like a medical condition. You get your metformin, you get your buprenorphine. So one of the things that I think the peers are really great at, but I think we also could work on, is when you're having these conversations about like, hey, you have an OUD, like, I don't want you to withdraw. We have these options for you. We prefer buprenorphine in the hospital because it's frankly just easier for us to use from both the legal and a medical side. But if the patient's saying, I don't want this, I want methadone, that's fine. Like, you can still treat them and provide this harm reduction service, even if they don't want the thing that we're good at. So bringing this back to the case, I think I actually wasn't involved in this case, but it sounds like this patient didn't want buprenorphine while he was in the hospital, which I actually think is appropriate because he had just had surgery. He needed sort of full pain, like full agonist pain medication. Couldn't get into a subacute rehab for his medical treatment, and he wasn't effectively, because he was wheelchair bound, he wasn't a good candidate for like inpatient substance use treatment. He was ultimately he was eligible for outpatient, but there were some barriers there. So this is sort of a good illustration in a lot of ways, in that patient preference kind of got run over by the system a little bit. He was interested in inpatient rehab. He probably would have been a good methadone candidate, but the reality of the system we have made it impossible for us to actually facilitate his preferences. Do you want to send me too? Okay. The other thing that the intersection between these slides is there's a lot of patient-sided barriers that are actually connected to sort of our knowledge gaps as well. So patients tend to be afraid of buprenorphine. I think, as Thaddeus sort of mentioned, a lot of people have had negative experiences with buprenorphine on the street. Most people who end up coming in for treatment for AUD have used buprenorphine that they've purchased on the street before, which people have really variable experiences if they're using sort of a lower dose than they need, if they're using it too soon on the street in a way that we wouldn't sort of recommend. They a lot of the time do have a history of precipitated withdrawal, so that'll be sort of a reason people give for not wanting to do buprenorphine in the hospital. This is something that Thaddeus is great at doing, something that I work in Baltimore, so I do this a lot myself as well, of like, yeah, acknowledge that you can have precipitated withdrawal, but there's strategies to avoid that. There's strategies to treat it if it happens. So this is a patient-sided barrier that requires us to have a pretty good knowledge base to actually have this conversation. Same thing with inadequate dosing, which Thaddeus alluded to in the era of fentanyl. What we're seeing is Baltimore has better numbers about this, but what we're seeing is that a lot of people using fentanyl, particularly in higher doses, are requiring closer to 24 milligrams a day of buprenorphine. So our protocol starts at 4, caps at 12, which is a very reasonable protocol. But if patients are like, y'all are just going to stop me at 12, we're not going to go above that, and that doesn't work for me, they're probably right. Like, they're actually telling the truth. So having this conversation of, we have this protocol, it's going to take a little bit of time, but we're not just going to give up at 12. We can escalate these doses. And probably this didn't work because of the reality of the fentanyl and the street drugs. The patient's concerns are accurate. they're telling you the truth. And it's sort of the reality of the changing drug scene. Thaddeus mentioned coming off of Suboxone is really, really challenging. I've actually had a couple patients here that have come to the ED for how the hell do I do this? It is a challenging thing. You don't have to take people off of buprenorphine. They can be on it long term. It is a maintenance medication. You don't wean people off of their metformin because they've been on it for 2 years. That's just not a thing. This can be a lifelong med. So if they're worried about that, they don't have to stop it. One of the things that Sumeet will talk a little bit about from a pharmacy perspective is so if people don't like the taste of the medications, there is some sort of literature that different formulations do taste different, and people tend to prefer tab form, and then the Zubsolv form tastes a little bit better than the brand name Suboxone. We have those options. If they say I don't like the taste, ask them what kind they've tried. We can give them something else. That's fine. And then a lot of patients, I'd say a lot, I've had this several times. A lot of patients will say, I'm allergic to naloxone before, or I've had a bad reaction to naloxone, which is true. They've had precipitated withdrawal from getting Narcan in the past. So a lot of patients really don't want anything that is a combo product. So if it's buprenorphine with naloxone, they're like, absolutely not. I'm not taking anything that has naloxone in it, which is valid. That's fair. We're going to talk more about naloxone because I have a lot of feelings about that, but we have buprenorphine monotherapy. It is completely appropriate to give them buprenorphine monotherapy if they don't want naloxone. That's not a big deal. So all of this, their misconceptions or their concerns about buprenorphine are not even misconceptions. It's basically that they have been on inadequate doses or used it too soon. And if we have the knowledge, like the knowledge base that we need, we can sort of allay some of these concerns. So this brings us to our side of it. So we can educate our patients better, but in order to do so, we have to know a little bit better. So one of the biggest things that we maybe buried the lead in this a little bit historically until, what was it? It was December 26th of last year. You had to have an X waiver to prescribe buprenorphine. That is gone. Every single person in this room, if you have a DEA license, you can prescribe buprenorphine. If you don't listen to anything else we say, please listen to that. You can prescribe buprenorphine. Historically, there have been these really, really high barriers to treating AUD. Thaddeus alluded to the replacing one drug with another. That entire attitude and the history of our regulation go back to this one guy, Hamilton Wright. This paper is from 1911. He just hated Chinese people and created all of these laws about the way we can treat people who use drugs based on xenophobia. So we have 100 years of bad policy based on this one guy being kind of a jerk. But now we're making progress on it. So ignore the 100 years of bad things. we're making progress. We can treat with buprenorphine, please do so. I'm gonna turn over to Sumeet for a pharmacology review.
I promise I'll try to keep it short and sweet because no one's going to be super nerdy about pharmacology than a pharmacist. So basically, buprenorphine is a high affinity partial mu receptor agonist. And what that means, just breaking it down, is that it's got a high affinity for the mu receptor. So it's preferentially going to want to bind to those receptors. More so than our full agonists, which are things like oxycodone, fentanyl, heroin, methadone. The partial agonist piece, it just means that it has less intrinsic effect once it's on those receptors. So you're not going to have so much of an impact on function. So you're going to get things like less respiratory depression, which we'll talk about. And there's also going to be less euphoric effects. And this is kind of going to be a key point when we talk about precipitated withdrawal, because as you can imagine, if you already have some of those other agents on board, buprenorphine is going to preferentially knock those agents off and bind to the receptor, and that can lead you to withdrawal. There are a bunch of formulations, the tabs, the films, all of that, and some of them do come with naloxone. And it might seem kind of counterintuitive to have an agonist with an antagonist, but the naloxone, if given orally, it's going to have zero effect. And then it's really just there theoretically as an abuse deterrent if a patient were to try to grind this up and try to inject it. So again, it's a partial agonist. It's got a dose-dealing effect for respiratory depression and euphoric effects. It's a relatively safe medication. You've got kind of a lot of room to maximize dosing for our patients, as we sort of talked about. And that's really to allow more of the drug to bind to more of the receptors and overcome some of these withdrawal type of symptoms. So this comes straight from our inpatient protocol. We want our patients to kind of be a little bit in withdrawal, so a COW score greater than 10. And that's really to make sure that none of the other substances that the patient might have used are still lingering on the receptor. So just so that we can allow the buprenorphine to act directly on the mu receptor. And again, that comes from higher doses. You're going to have more receptor activity. I think the big thing here is to note, kind of as we've touched on, that this is a starting point, and it's just kind of a guide for everyone to use. You're definitely going to want to tailor this to your specific patient, and that comes from having conversations with the patient, saying what they were on outpatient or at home, conversations with our peer recovery coaches and seeing what the estimate is, like, is it going to be moderate or is it going to be severe? And sort of taking all of that stuff into account. The other point that I will make is that if a patient was loaded in the ER, those doses are definitely going to be higher, and you shouldn't try to taper those. You're going to kind of keep them going. So contraindications, it's pretty straightforward. The real contraindication is a true allergy to buprenorphine. It's a relatively safe medication. The things to keep in mind are what we talked about as far as last use of illicit substances. We sort of touched on special populations, pregnancy, and exclusion criteria. And that's not to say that you can't use buprenorphine in those patients, but you would want somebody that's a little bit more of an expert and a little bit more phoning a friend, to say the least. So at the end of the presentation, there are going to be resources for everyone to utilize if they were to come into these special circumstances. So managing the precipitated withdrawal. It's important to remember, if you haven't kind of gotten the hint, that buprenorphine is pretty safe and it's pretty effective. It's well tolerated. It's pretty uncommon to go into precipitated withdrawal, but it can happen. And it's kind of important, I think, to determine the etiology of why this patient's going into withdrawal. Similar to if you had a patient that has a past medical history of hypertension and they're presenting with a hypertensive crisis, you're going to ask more questions. You're going to do a little bit of digging. So what that can look like is really honing down that timeline of last use of full agonist that we talked about. Is it accurate? Is there a little bit of wavering in those scenarios? Was the starting dose of buprenorphine too low? Again, this is going to go back to talking with the peer recovery coach and seeing what the estimate is of how severe the withdrawal symptoms going to be. And then the other thing I think from a pharmacy perspective is really just the administration of the buprenorphine. We talked about how patients have different, I guess palatability is the best term to use. So did they actually let the film or the tablet dissolve completely, or did they swallow it, or did they spit it up because it tasted really bad? So all of those things are what you want to take into consideration. It's going to help you determine your management for treating the precipitated withdrawal, which I think probably the best scenario, and it seems kind of funny, is to actually add more buprenorphine. Our protocol has some guidance on this, so 4 milligrams every 30 minutes, up to 24 milligrams. And again, that's just, it goes back to the idea of adding more of the drug to hit more of those receptors and get you over that withdrawal. Other adjunct therapies are definitely going to be things like NSAIDs for pain, Tylenol, antiemetics, things like that.
I just wanted to, sorry, this is like a big issue in that we get really afraid when we see precipitated withdrawal. We get concerned that we've caused something, and we worry about giving more. This is not an unexpected reaction. It's less than 2% of patients, even in the era of fentanyl, have precipitated withdrawal, but it happens. So if your patient precips, if their symptoms are getting worse, don't freak out. It happens sometimes. Just give a lot more fast. Like Sumeet mentioned, since there is really no respiratory depression to this medication, there's no risk to going in high dose. There have been case reports up to like 64 milligrams on the first day. So if you're getting the patient up to 24, you are well within a therapeutic window. And the bigger risk is discouraging this patient from ever taking any medication ever again, and then going on to overdose and die. So you giving them 12 milligrams, 16 milligrams, 24 milligrams is not a risk relative to them overdosing because they can't take anything else. Sorry, that's my personal soapbox. I'm just talking about that all day.
Okay, this slide, I promise, is the last one for the pharmacy perspective of things. It's just here for reference. The big things to note, we have both monotherapy and combination therapy here in-house and also in the outpatient pharmacy. So basically, whatever your patient's preference is, we can definitely accommodate that. And then the other big key point, again, to emphasize that you all can prescribe it as long as you have a DEA license. So that's it.
So we're going to fly through the rest because that was sort of the part we actually want you to take away is please prescribe buprenorphine. We do have a lot of stigmatizing attitudes in healthcare. I don't think that's anything. I mean, it's hard for us to confront that as providers. We want to do our best by our patients. We also are sort of informed by growing up in the, I think we all went to DARE classes in elementary school, and Nancy Reagan's just say no thanks. So we do have these internalized biases. We need to unpack those. We need to acknowledge that as providers, we have to go a little bit beyond sort of the way we were raised. We need to normalize treatment. If you're in a primary care setting, if you're doing outpatient medicine, this is something you can do in your clinic. You need to sort of look at our language. Are we saying patients are clean or dirty? And is there language that we could use that's better than that? And then we need to just shift our mindset of, the conversation I always have is if someone's diabetic, I don't refuse to treat them until they stop eating sugar. I just treat them. And this is sort of the same thing if you need patients where they are. We're going to sort of fly through systemic barriers. Basically, a lot of this relies on community health and connection to treatment, which is challenging everywhere. It's particularly challenging in DC because of the reality of what DC is. There's a lot of pay parity issues, and as far as there aren't a lot of addiction docs, there aren't a lot of people that are doing this in a primary care setting because it's really hard to get reimbursed. There are issues. There are some advocacy opportunities to sort of get involved in this. There are some, this is boring and I will try not to focus on it because if you want to talk about how to get involved in advocacy, please send me an email and I will talk to you about this all day. But the biggest thing is prescribe. Like the biggest thing you can do is prescribe you, treat it like any other medical condition and just stop being afraid of it. Georgetown is doing quite a few things to sort of expand these protocols that we've already started. So I think it's with Rita and Thaddeus have mentioned, we already do Narcan distribution and education in the ED. We're working on expanding that. So any patient who's getting any form of opioid or who has OUD from the inpatient floors just leaves with Narcan in hand. This is grant funded, so it takes a little bit of time, but in the meantime, you can text Live Long DC, just Google Live Long DC, and they will just mail you free Narcan. They'll mail your patients free Narcan. They'll teach you how to use it. We're working on fentanyl test strips the same way, working on filtering our notes to make sure we're communicating better with our peer counselors. We're sort of, all of these processes, we're doing continuous quality improvement, and we are just really pushing for all of our providers. So obviously we have sort of like internal medicine psych today. We do a lot of ED education, but surgery should be doing this, anesthesia should be doing this, OB should be doing this. This should be something that is just standard of care. There are some opportunities where as a system, I think we could probably make broad level changes that if anyone has any connections, I sort of encourage to sort of help work with this. I mean, we always need more peer coaches. Thaddeus is wonderful, but unfortunately he cannot work 24/7. So it needs sort of expanded coverage there, community health advocates, and just making sure these patients are able to connect to the treatment they need. We have a lot of resources here actually. The master's program that Thaddeus is starting in like a month has actually a lot of higher ups within the federal government who in the DEA and the Office of National Drug Control Policy. So there is a lot of opportunities for the hospital to partner with the law school, with some of these organizations to really make high level advocacy changes. In your clinical practice and in Georgetown sort of protocols, I think there's a lot of opportunity to sort of address where we have protocolized stigma. So things like, are we calling patients disruptive? Are we calling them drug seeking? Are we putting in high alert notes that say this patient's just here for meds, rather than sort of unpacking, okay, why is this patient using heroin on the floor because their pain's untreated, because we sort of failed to identify this problem, and to sort of, rather than calling this patient disruptive or calling this patient a drug addict, how can we actually address the root cause there? And then my pipe dream is sort of expanding these alternative models. Right now, this is a wonderful protocol for us to sort of start buprenorphine and provide this MOUD without having an addiction consult service available to us. I would love for us to have an addiction consult service or a bridge clinic or someone who's doing the addiction work within Georgetown and within MedStar. We don't have that right now. I think it's a great opportunity to expand. I do have a resource for you, but I'll hand this back over to Rita real fast.
All right, so really quickly for my hospitalist, check your bias, just like what Dr. Haseldon just said. Ask about substance use history and treat it. We've normalized asking about substance use history. We learned all about it in medical school. Now we should normalize treatment of it. So follow up your questions about opioid use with, are you interested in buprenorphine treatment while in the hospital as you're getting your HPI or completing your H&P? Be sensitive to possible higher pain medication tolerance in the hospital. Have a lower threshold to look for opioid withdrawal. Use the fentanyl urine screen. Unfortunately, our UTOX screen doesn't include fentanyl on it. And so frequently we'll have a UTOX screen that is negative for opioids, but if you get the fentanyl screen, it's positive. So,
Oh, it does. We're working on updating that.
okay, all right.
Soon.
And then use DAX, which is the district
Next slide.
addiction consulting
There it is.
consult service, so that if you have any more complicated questions, as we said before, our protocol is very basic. It gives you the starting steps to start buprenorphine, but there's a lot of patients who have more complex medical issues, who have more complex pain issues, and those patients should not necessarily not have access to MOUD because of that. And so the addiction consult service is run out of University of Maryland. They are available to call, so that if you have any questions about titrating buprenorphine, where you need a true addiction specialist to help you with that, there's access to that. And kind of going back to our patient case, again, to run the point home, the patient, there was actually never any documentation about OUD or chronic pain in his H&P. And so as a result, the patient's pain was not well managed in the hospital. APS was never called for him in the hospital. No, there was no, this patient was here before our screening process or universal screening was in place. So my hope is that with this universal screening in place and with our peers availability to like see our patients, rather than wait until after the patient overdoses, in the hospital, hopefully, like as Thaddeus saw the patient in the hospital after, hopefully we can address it on the front end.